Okay, good morning everyone, and thank you so much for coming along to this talk on an introduction to continuous glucose monitoring. My name's Ian Ramsey, and I work at the University of Glasgow. This is the hospital, and in this hospital on Saturday mornings we run a diabetic clinic. So this is where we take in the cases that have come to us through the months and weeks and so forth, being referred in, but also quite a lot of first opinion cases are coming through this clinic now. That's my qualification, if you like, for talking to you today about continuous glucose monitoring. There are, as always in these talks, some conflicts of interests, and specifically in the context of this talk, I have to declare a conflict of interest that Woodley Equipment have paid for me to come and paid for me to give you this talk today. Okay, so there's a conflict of interest there. But I have lots of other conflicts of interest as well, most of which I don't think actually matter all that much. A quick nod to Kit Sturgis as well, who I talked with at BSAVA Congress on this topic, and I nicked a couple of his slides. Very unprofessional of me, but I'm acknowledging him so I get away with it. Okay then, so our plan today is to start with an introduction, a background that I think is important before we even start talking about continuous glucose monitoring systems. Then I want to just explain how they work, and that has impact on what we're going to see next. You may not think, oh, it always sounds about electrophysiology and all the rest, but I'm afraid we have to understand it in order to understand why they are used in the way they are used, where they can go wrong, and about that. And then how to interpret the data. And I'll finish with a couple of interesting case examples just to see how things are going. This is Dexter. Dexter is a cat that was a diabetic cat that was treated with Senvelgo, developed euglycemic DKA, was then treated with insulin and went into remission, and still 3 years later is still in remission. He was 14 years old when we started. He's now 17. I know it because his owner is my tennis partner. Okay, let's start with an important document, which is the Alive Consensus Statement from the European Society of Veterinary Endocrinology. If you haven't seen this, this is an important piece of background information. Tina, I'm afraid you're going to have to sit right in the front. And this is an important document. It's a group of endocrinologists got together and they talked diabetes. And what was the best method of controlling diabetes and monitoring diabetes? And after a lot of meetings, they came to the conclusion clinical signs are paramount. The job of our treatment for diabetes is to remove the clinical signs of diabetes. If you are still getting clinical signs of diabetes despite treatment, you're doing something wrong. Time to think again, okay? We want to normalize the body condition score, PPD, ketones, and so forth, and there is a scoring scheme which we'll come on to. We know that good control is related to glycemic control. However we assess that, but there is no specific goal. I'm not going to say that you've got to have an average blood glucose of 8, 10, 12. Clearly, if it's 25, you're going to have problems. But 8, 10, 12, don't know. We don't know. In humans, we do. We know in humans an HbA1c over 7%, and your life expectancy goes down with each percentage rise beyond that. We can tell you that. But I can't tell you that for dogs and cats. And because dogs and cats live a shorter time frame with their diabetes, so some of the parameters that we might translate from humans aren't appropriate for our patients. We don't need to worry about a dog that's going to be on insulin for 15 years because they're unlikely to live that long anyway, whereas human beings may be on insulin 20, 25 years and develop all sorts of complications. All current methods of assessing glycemic control have problems. Whatever blood glucose curves and so forth we're talking about, fructosamine assays are unreliable. If you send a fructosamine assay to 4 different labs, you get 4 different results. And they are diametrically opposite interpretations. And that's got to worry you. If you muck around with a sample, you can muck around with fructosamine concentration. Urine glucose, I do it, but you know, it doesn't really unvariable. And probably the most important thing, going back to that paramount section of the time about clinical science, is this concept of the Alive Diabetic Clinical Score. Now, if you haven't seen this, this is what it is. It's on the Alive website in the European Society of Veterinary Endocrinology. And this basically is just a scoring scheme, which hopefully you would have asked all these questions of every diabetic every time. Hopefully. I know when I went back, when I was doing work with Cushing's, and I went back and looked at clinical records, we may have asked the questions, we sure as heck didn't write the answers in the notes. So the advantage of this is not so much teaching you clinical medicine as making sure you record it, because it matters if that dog is not PUPD. As vets, we tend to record what's abnormal, what's normal. But in fact, in diabetes, what we want to do is record the normalities as well, not PUPD, not polyphagic, and so forth. Okay, so this is a scoring scheme. It goes up to 12, and the idea is to keep the value as low as possible without risking hypoglycemia. Okay, where do we start with all this? I think this is an excellent paper here from Linda Fleeman and Jackie Rand. These are 12-hour curves. There's the normal, these are American units. This red line here is the renal threshold. So that's the point at which you go. It's 10 millimoles per litre in millimoles per litre. And you can see the normal range down here in grey. So we have 6 curves here. What do we think about? Can we interpret those? With difficulty. Yes? And what's more interesting is if you give those 6 curves to 6 endocrinologists, guess what? They don't agree either. Even if we think so. We don't know how to interpret these curves very well, and they are substantially different. Now, the really worrying thing I found about this is not 6 different dogs. This is one dog coming to a hospital on 3 separate occasions, each time getting 2 curves done, one in the day of arrival and one the following day. No change in insulin dose, timing, exercise, or food. The inconsistency there of blood glucose curves must give everyone a pause for thought about using blood glucose curves. Yeah? This one here, you'd probably reduce the insulin. You'd probably increase the insulin. Yeah? Even if we look at that, probably the only thing that you can do with this data is take an average. Yes? And clearly, you can't go around assessing your diabetic patients by doing 6 blood glucose curves and then saying, hey, now we're going to make a decision. And what this study was actually set up to do was to look at the effect of stress. So it was between the day of arrival and the next day, and looking at the difference in blood glucose curves on the effect of stress. So if you're bringing a dog into your hospital to do a blood glucose curve, not only have you got all the other factors, but you've also got that effect of stress. And that can be huge. It can take a normal, healthy, stable diabetic and turn them into ragingly insulin resistant for that day. Whoa! So, clearly, there are problems. I have a confession to make. I have not done a blood glucose curve in a healthy, normal diabetic in 15 years. Abandoned it. Just stopped. When I saw that paper, I thought, this is crazy. So please, if you feel like I do, stop doing blood glucose curves as a way of assessing stability. The way of assessing stability is the Alive Diabetic Clinical Score. That's the most important. Now, from that, of course, what we might want to do is to monitor glucose at home. We clearly can't monitor blood glucose at home, but we can monitor interstitial glucose. And continuous glucose monitoring systems have been around in small animals for some time. Lucy Davidson and Jelena Ristic published on the Minimed. Great, but it was 4,500 pounds and required a backpack for the animal to carry around. iPro, Guardian Real Time, I did quite a bit of work with the Dexcom G4, great, except that little bit there was 600 quid, and every so often the nurses threw it out with the bandages. And even more interesting, there are now implantable systems. So this is the Eversense, which has just been published by the Italian group, showing something like 3 months of glucose readings from an implantable microchip. The technology is coming. But all these had very serious shortcomings. One way or the other, either they didn't give you the data, or they gave the data, or they gave the wrong person the data, or they were just impractical. Until the flash glucose monitoring system called Freestyle Libre was introduced. If you went onto human diabetic forums, it was a paradigm shift. Until then, continuous glucose monitoring systems were rarely used. Then, almost every diabetic had a go in the UK. It was massive in human diabetes. Theresa May, who was a diabetic, through the Brexit process, she was wearing a Freestyle all the time, and I bet her diabetic doctor had a close eye on her diabetes because that was stressful for her. Yes? Okay then. And following on from this, of course, the logical thing was that we started to stick them on dogs. These were now affordable. They were easy to apply. They seemed to be able to stay on, which was also a big problem with older systems. And Federico Fracassi's group published a sort of what I think is a landmark paper looking at this flash glucose monitoring system. The problem with the Libre is that it's for humans. It's designed for humans. It is calibrated for humans. And if you phone up Abbott, who make this, and say, "Hi, I'm a vet, and I put a Freestyle Libre," hello, 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 they hang up. They have no interest. I don't know if any of you have tried, but if you try and contact them, they're not interested. They have taken an executive decision, do not get involved with the veterinary market. And as far as I know, they're not going to change that, which is interesting for a company that also makes the Alpha Track 3 for veterinary use, but never mind. So we have a bit of an issue, and I've been working with Woodley's now for about 6 months on their InSight continuous glucose monitoring system. This is essentially another glucose monitoring system, but it is designed for veterinary use. It is calibrated for veterinary use, and it comes in a different set of packaging. If you're used to using Libras, you're going to have to learn how to use one of these, but trust me, it is just as simple, and we'll be talking a bit more about that. I should point out that downstairs there are 2 other firms advertising continuous glucose monitoring systems. I've been around them. Neither of them have got any validation at all, and then one of them isn't even on the market yet, so, but it's clearly coming. But this is a veterinary one. How do they work? Okay then, so this is a little Freestyle Libre, which I put onto an edge after I've taken it out of a dog, just to show you how it works. And you can see the sensor here sticking down. This sensor is not made of a hard material. It's flexible, okay? So it's very comfortable. The animal can move and the thing can move and it doesn't hurt them. All right, I think a lot of people, when you see the applicator, there is a needle in the applicator, but when it's applied, the needle is withdrawn, and what's left is the sensor, and that's flexible. It's about the sort of flexibility of PDS suture material. Okay. If you take an electron microscope and you look at that sensor, this is what you see. You will see carbon patches connected to electrical circuits, and one of those carbon patches has a glucose oxidase impregnated into the electrode. Okay? And then what happens is when you've inserted this into the animal, it lies underneath the dermis in the subcutaneous area, and it lies within the interstitial fluid. It does not sample blood glucose. What happens is glucose and oxygen come along in the blood, they diffuse through into the interstitium, and that glucose and oxygen working with the glucose oxidase produce gluconic acid, hydrogen peroxide. Hydrogen peroxide breaks down immediately. Hydrogen peroxide generates electrons. That's an electrical circuit. So the quantity of glucose is proportional to the electrical difference. So we measure the electrical difference and therefore work out what the glucose is. That's how things... Now, 2 things, okay, immediately. You've got to have a blood supply, okay? So if the blood supply is compromised, then the glucose concentration will fall. And it may not have to be that much compromise. It may only simply the animal, a big heavy dog lying on the sensor would decrease blood flow. Oxygen levels. So if the animal is hypoxic for some reason, then that's going to be a problem. And of course the pH. So if the animal is acidotic, it could affect this electrical activity as well. So there are some implications of this which are important when we start to consider about why these things work and when they're best used. Okay. I spent a long time teaching owners this, and they do not measure blood glucose over and over and over again. People say, I got a blood glucose of 10 and the continuous glucose monitor said it was 6. The continuous glucose monitor, ergo, must be wrong. No, it must not. Inevitably, it may be that there is a lag phase between changes in the plasma glucose and changes in the skin glucose. I teach my clients these devices measure skin glucose, and it's only a marker for the blood glucose. But from the studies done in Italy, it's a pretty good marker. Yes, this is Freestyle Libre data, but it is a pretty good marker. This is what we call a Bland-Altman plot, which looks at the difference between blood glucose and skin glucose without making a judgment about which is best. Okay, and you can see here that around the normal range here, there's loads and loads and loads of dots all bunched up there, and it really is quite good. And as it spreads out, there is a variation, but 90% of the values lie within plus or minus 15%. So it's pretty good, pretty good. If you then assume that the reference glucose is in fact, the blood glucose is in fact correct, and then you're testing your skin glucose, then this is what's called a Parkes consensus error grid. So anything in A or B zones are clinically acceptable. B just requires a little bit more interpretation. Anything in C, D, or E are going to lead to the wrong clinical decision. Of course, the problem with these, and this would suggest these are good things as well. The problem is that these are all points, and what you've actually got is a curve. And clearly seeing it in the context of the curve is more important. So I've always said the pattern is more important than the value. At normal and low concentrations, there is a tendency to underestimate using the Libre. So if the Libre says it's 3, there's a tendency the blood glucose to actually be 5 or 6. And that's important when you look at these values. Okay. Problems, very few. One person, I think very people are very, I've had this reported, some of my colleagues have always been very, we can't put it on the thorax of a cat because we might get a pneumothorax. There's been one case ever. And you really would have to try very hard to do that. It only goes 3-4 millimeters, and if you do chest drains, you know that even the thinnest cat has usually a more of a subcutis than that. But undoubtedly, the problem with very thin animals doing it over is that because the ribs, well, including some diabetics are thin, that's why we talk about it, it's undulating and therefore not a very good surface. So finding an appropriate site is important. About 40% of animals, when you remove the continuous glucose monitoring system, will have skin inflammation underneath. And again, it's something to warn the owners about. And I'll try to encourage owners, because some owners will put device after device after device after device on their animals, because they can buy them on the internet, these Libres. And I do say it does actually irritate the dog veins. Very rarely we've seen more deeper skin erosions. I've seen that, and I've had one abscess form at the site of insertion. So it is worthwhile just remembering that. The other limitation on the Freestyle particularly is that it only goes up to about 22, 27. Now that's probably clinically not that relevant because anything over 27 is clearly hypoglycemic anyway. But all the same, I do like to, if I've got a dog that's sort of 35 and so forth, clearly I'm going to have to increase insulin. But I do like to see a bit of a curve to get me my response. The new InSight one has an upper limit of 42 millimoles per litre. These things have been hugely welcomed by owners that have done this. Many owners that were practicing blood glucose curves at home have switched completely to continuous glucose monitoring systems. 92% reported better control. The only real problem was the cost and the idea that actually these sensors fall off. About 5% of hours fall off before the week is out. So I actually do a deal with my owners now that I basically say, I'll guarantee it for a week. And I price it accordingly so that I can get a week's worth of values. And if it falls off during that week, I replace it free of charge. And that has helped a lot with my owners' acceptance of this, because the people who've had these on before, they know that, you know, sometimes you spend 50, 60, 80 quid and it falls off 2 days later and you think that was a waste of money. But if you do that kind of pricing model, it works quite well. And well, we shouldn't talk about profit too much, but maybe we should talk about, I'm running these at a profit. Keeping the sensor attached to the cones. Cats seem to tolerate these sensors less well, and again, this problem of how they're lying is important. So that's why I don't like putting it too far down on the flank. I'd prefer it on the dorsum because they don't lie on it. Okay. Note this cat, the owners put a vet wrap on it. I don't particularly like that. I think it's a fairly occlusive dressing, and I'm not surprised that the cat's been in an attempt to try to keep the cat on, because the sensor on the cat, of course, cats use their claws and they do flick them off. Okay. When should they be used and when not? First of all, where do I put them? As I said, you can put them on the flank, on the dorsum, over the shoulder, and I think some understanding about how the dogs sleep, where they sleep, what their activity levels are, how easy they find it to get, and an assessment of how easy they find it to get their claws up the side. This all influences us. For the most part, I tend to put on the dorsum for reasons already given, but I will acknowledge that some go down on the flank as well. Select a fresh site. So if you've had one, you can't put it on the same site, because that has skin inflammation. And that inflammation is altering blood flow to the skin. So clearly you may not get the same results. So we always choose a fresh site with no skin lesions. And again, that might be an issue with an atopic dermatitis case. We haven't looked at that, but that's something you've got to think about. Clip and clean the skin thoroughly. And it really does need to be clean, because that glue is going to have to stick on for 2 weeks. There's a good glue on these things now. But still, if you don't clean the skin properly, they will fall off. Deploy the sensor and attach to it. Now, there's a bit of debate about whether you put a little dot of super glue or sorry, not super glue, tissue glue, not super glue, in there. Some people do, some people don't. I know Kit doesn't. I do it for some. I've started to try to move away, but I still have this need to put a little bit of glue. But what is important is that you don't cover this with an occlusive dressing. Okay? Oxygen has to be able to get to that sensor. So covering the sensor with a really occlusive dressing, obviously a permeable dressing is fine, but occlusive dressing is not reckoned to be a good idea. Okay, I'm just going to show you a very quick video now of this new device. So you prime it by pushing that button there. You tear off the top tab. There's your button. Press on it carefully. Locks in place. That now inserts the sensor and the transmitter together. You can see in there the sensor and transmitter. This thing is about the size of a £1 coin. Here's the victim, diabetic dog. Can't actually see the clipped area very well, but this has been clipped and cleaned. And put in there, and bang. And you see that the dog hardly reacts. Yes? Note that we do keep it still for a while. Let the warmth of the animal warm the glue up, okay, before you try to move it. It gets a better bond. So I do what they're doing here, which is to hold it, and then give it a little shuggle, that's the technical term, and it comes away. And that's it, done. It's that easy. I don't do this anymore, my nurses do it. Okay, we just get the nurses just fit it. When should we use them? I think we should use them, particularly use them in initial stabilization, because it allows for a more rapid and more effective insulin management. Particularly in cats where I'm going for diabetic remission, I want to move quickly. For dogs that are, obviously they're going to be on insulin for the rest of their lives, the rapidity of getting it is simply to get the dog in a better state earlier so the owners feel more in control of what's happening. It's really important. We know that 25% of diabetic dogs die in the first week or two. Now, some of those will be ketoacidotics and all the rest, but we are losing 25% of our patients because owners lose faith in our ability, either or their ability to do it. So it's really important to use it early. Then we use it for those dogs which have a poor response to insulin. So after, I give myself probably about 6 weeks to stabilize a dog, maybe 4. If I'm using a freestyle. If I'm not getting anywhere, if things are not a problem, then we've got a poor response to insulin and we need to change what we're doing. Also for those dogs which are apparently very hyperglycemic one day, and miniature schnauzers are my poster breed for this. They're hyperglycemic one day and then they're great for another 3 days. And then they go massively hyper for no apparent reason. So those are well investigated using these kind of things. And finally, for those where you think the diabetic cat is actually entering remission. So we're giving the insulin, and we are seeing these cats having persistently negative urine glucose. So we lower the dose of insulin, still negative. So we lower it again, and I think this is the point I want to freestyle to see what's going on. Okay. They are less valuable when there's a blood glucose available anywhere. I'm particularly eyeing up here the intensive care cases. Diabetic ketoacidosis, because of the acidosis, because they're recumbent, and because I've got blood glucose anyway, I am less inclined to put on a continuous glucose monitoring system on these critical care patients. I'm not saying it's without value. It can help in the ICU, particularly patients that are less than amenable. Yes, then it makes sense. The problem we found in our ICU is making sure that we've got a phone that we can use with this device. Because everyone says, yeah, well, let's put it on, right? Who's going to give me their phone? Well, when you've got a bunch of young vets, that's like severing their umbilical cord. No, I'm not giving you my phone. So you have to have a phone, obviously, if you're going to do it in your ICU. When can they be unreliable? So in theory, these devices at the moment all last 14 days. Most patients, you can get 7 to 10 days usable data, but after 10 days, they can start to become unreliable. Usually in the last 12 hours, they can really go and give you some really odd results for those last 12 hours. So don't, the last thing is usually, ignore it if it's the last thing. And there are, and I'm going to say 1 in 20, possibly, I just can't get them to work. I don't know what it is about that particular dog, but it just doesn't work. And I've had probably a couple now where we've tried it a couple of times and it's not worked. Cats as well, particularly that's where that thin skin problem comes in, is where they've got very thin skin. And in fact, what you're ending up with doing is almost inserting it intramuscularly in these very thin cats, and I think that's the problem. We know they don't work in anaesthetized patients. Okay, so this is not the thing to put on a diabetic dog if you are going to take it to surgery. You should, if you're anesthetizing it, you've got an IV line, and you should be measuring blood glucose. Because what happens under anesthesia, the blood glucose changes too fast for the skin glucose to catch up. There's nothing wrong with the device, it's you're measuring the wrong thing. So under anesthesia, please, please, please use blood glucose. I have some concerns about them in dehydrated animals. That study's not been done, but the very dehydrated animals, I intrinsically think the interstitial fluid, because they're dehydrated, must be different. And therefore, you are going to see, over the days that you rehydrate them, you're going to see a change in what the measurement. It'll give you a measurement, but whether it's accurate or not, I don't know. Also, they know that if you in human beings, if you eat your dinner, your blood glucose can go up really quickly, and the freestyles don't cope with that so quickly. They take 15, 20 minutes before they acknowledge that something's happened. And DK, and I'd say in this, honestly, there's data there that says it's okay, but my personal experience is it's not good enough. I have Freestyle Libre saying the blood glucose is 4, and actually the skin glucose is 4, but the blood glucose on measurement is 14, and that alters what I'm going to do. It's not a pattern then. It's much more about things. But I think it does have a role where you're wanting to look at a pattern and wanting to time your blood glucoses a little bit. But generally, because of this lag period, when the blood glucose is changing rapidly, these things aren't so good. So these are really for the happy, healthy diabetics, or the relatively happy, relatively healthy diabetics, than it is for the very sick intensive care. And I think that's something we could probably have a bit of a debate about. Okay then. So we know we're going to use them on the outpatient basis. The owners are going to have to be set up. My advice to you is, if you've not done this, is that make an assessment of the owner's IT. There's a large number of people wandering around with smartphones who have no idea how to download an app. And you think, God, everyone can download. No, really. There are people out there who've got this fantastic piece of technology. They don't know how to download an app. They don't know their passwords. One owner eventually, she was in her 70s, 80s actually, 80s. She needed to bring her daughter in because daughter managed the mobile phone. So please make that conversation, because without the mobile phone, none of this works. So, and unless you particularly like spending an hour of your life trying to sort out an 80-year-old's mobile phone, get the people in. I've been there, got the badge on that. Please make sure you get the people in to do it, to make things. Once you've got that, then what happens is this. Bang! You get masses of data, and you're sat there going, what the heck? This is off my personal mobile phone, so I'm linked up to all my freestyles that I've put in. And you're just scratching your head and you're wondering what's going on and so forth. And I've got thousands of these things, and to this day, I always think, actually stop looking. First, so how to interpret this? First point. Most of us, when we saw blood glucose curve, saw them in a landscape format. And now we're looking on a mobile phone in a portrait format. These two curves are the same. But a trick of your mind's eye, if I just put that one up on the right there, I would have no problem convincing everyone there's a Somogyi overswing here. This one, the rate of glucose increase is not consistent with what you might call a Somogyi overswing. And that's before we start the debate, does even a Somogyi overswing exist? Yes? I can have another debate about that. I don't believe Somogyi overswings exist, but there are people who do now. So that's the first thing. So you want to try to get this into landscape format. So having got it in landscape format, the second thing we need to do is to look at the average glucose profile, the AGP. These are a median. The black line is the median, and the blue shaded areas are the variation. And where there's high amount of blue, there's a lot of variations. And what this saying is, yeah, sometimes it's down here, but sometimes it's up here. Whereas here, there's possibly less variation. Yeah? But that's what I start looking at. Look at the average in the first place. With the InSight, they actually give you a PDF of a printout. That makes it even easier. This is really, quite an interesting thing. Over 24 hours, you can see this. The mean of this dog has fluctuated between 20 and 10, occasionally dipping down. And there's a lower limit there that's always above that threshold of 5. So we're pretty happy with this, but there's also quite a lot of times when this dog is quite hyperglycemic. Okay. So how do we look at, how do I interpret this? So I take my AGP and I measure 3 things. The first, from the point of injection of insulin to the point when the glucose starts coming down, this is the time of onset, the duration of onset. The second thing I measure is the lowest that it reaches, which is the nadir. And the third is when it breaks through it goes back to the insulin level not working anymore, and that's a duration of action. And from those 3 pieces of information, I can tell you what you need to adjust in terms of the dose, the insulin type, and the frequency. And that's probably the most important information you can get out of this. Probably the most common curve I see, the median curve, is the one on the left here, and it's insufficient insulin. That's probably the most common curve we see, that simply we need to increase it, because at no point in this median curve have we got the median less than the renal threshold. At no point have you given enough insulin here to achieve control in 50% of the time. So maybe you've got 10% of the time you're down here, but that's not good enough. The second curve, which I'm seeing really commonly, is where you've got the median down to somewhere between 5 and 10, maybe down even in the normal range. But then there's a rebound very quickly, and you lose it. And in those cases, you need a second insulin injection to keep it down. And I see quite a lot of once daily can insulin treated dogs that really should be on twice daily, really should. PZI may be useful in some dogs, but even then sometimes I have some dogs on twice daily PZI. And actually, I've had one dog on two dogs where we swapped from can insulin to PZI, and we think that there's a difference duration in action. Didn't see it. So it just goes to show it's a very individual choice. Yeah, and if you've tried can insulin and you've tried PZI, then you may have to go on to things like the human insulins, like Toujeo and so forth. There are other ones out there. You have to adapt your insulin to your dog. There is no, and I hate people saying, practice protocol for diabetics. Tear up your practice protocol for diabetics. You have to do it individually. It's an individual thing based on this sort of data. Having looked at the average, I then do look at the curve over time, because these things hide in plain sight. If you just look at the average, you need to look at that curve. And you can see here, this dog here is low, up, low. Now, here's my worry. Are these really lows? I don't know how many of you use Freestyle Libras, but you've probably had a few hypoglycemia. You've seen this hypoglycemia, and you thought, oh my God, they're having hypo. My experience with the Freestyle Libre was that, no, actually when you do the blood glucose, even when it's relatively stable, the blood glucose was a bit higher. And that's that point that study made, that hypo on a Libre is often normoglycemic when you measure the blood. Okay? But clearly, something went on that day that didn't go on the Thursday. And same thing happens here. This is a InSight meeting. You can see here several days of up, down, which is what we'd expect, twice daily. This is a dog on twice daily PZI, twice daily. And then something happens here, and wham. Now I've got a whole load of lows down here, and everyone's getting a bit worried. What's happened here? The only way you're going to find that out, and the real sort of take-home message from this talk, is there's no point putting a Freestyle Libre or an InSight CGM on unless you're doing some sort of home monitoring, unless you've got some sort of diary from the owner telling you what's happening. Because otherwise you're completely flying blind. Both of those, something happened, but what? In the first case, there was that dog was actually sick that day and hadn't eaten. And in the second case, the high ones were actually reflecting the fact that the dog had pancreatitis, and then it got over it and was feeling better. But only by taking home monitoring records and looking at, yes, I also like looking at urine tests, because sometimes when you look at the data and the urine tests, there's a discrepancy there, which I think you need to be mindful of. But certainly things like vomiting, diarrhea today, not a good day today, feeling miserable, really help you interpret what you're looking at in these curves. I get sent quite a lot of PDFs from people, and they send me this PDF with all these graphs coming down, and they say, what's going on? And I say, well, I don't know. You tell me. You've got things. Keep the owners keeping records. Best if, most of these apps now, they do have events that you can put in, but most of my owners seem somewhat reluctant to put those events in, so at least have them record it on paper. So then you can look at. Okay. What I've been doing over the last couple of months, really, I've had a couple of dogs where the owners have been pretty intense, I would say, about their freestyle Libras, and they've been concerned about these hypos they're keeping in, and I've persuaded them to have 2 meters at the same time, one of the InSight and one of the freestyle. I'm going to present you now with the data that we've collected from a couple of these dogs. These are preliminary data. They haven't been published. They haven't been verified. So please don't take it away as gospel, but I think there is an important message coming through from this. The pink line is the InSight meter, which used to be called the Fur Carer, but it's now the InSight. And the blue line is the Libra. And I think it's worthwhile pausing and reflecting. What that line's telling you is that by and large, the InSight is giving you the same curve, but at a higher level. And given the number of these hypoglycemias that turn out not to be hypoglycemias I'm getting with Libra, I'm guessing this is the thing. Now, unfortunately, this dog, I mean, apart from here, where it did go hypo on the Libra, but the freestyle said it was on, and I've got no blood glucose to back up on any of these. These were done at home. Okay, so I haven't got any blood glucoses from these things. But clearly, if you're used to using the Libra and you're going to move to the InSight CGM, then you have to start thinking about what you've been used to on the Libra won't necessarily jump over to the InSight CGM, but there may be higher values. If you put that into graphs, the correlation is pretty good, actually, if you look there. But you can see that increased value as time goes on. There is clearly a bias there. But notice that it's all between about plus or minus 5 millimoles per litre, something like that. So that's the sort of measure of difference that we're talking through. Having looked at that from one patient, we went on to do another, and same results, essentially. So it wasn't just a one-off. This dog here was wearing 2, and again, you can see here that the Fur Carer is measuring slightly higher. The InSight measures slightly higher, and that may be good. That may be good, but I can't tell for sure on this. Similarly, the correlation also very good. Similar bias, because this dog was much less stable. You can see all the blood glucose is there over 20. That this dog was showing considerable bias at higher values. So hopefully that has shown you the difference between these two, but also encouraged you to use these devices as a way of assessing your diabetic patients. I'll leave you with a couple of quick case examples here. This is Annie. This is actually that miniature Schnauzer you just saw. Annie wears 2. This is another set of data from her we had. And this is what I would consider a good curve. This is what we want to see. Now, I've got no proof that is, but I can tell you her live diabetic clinical score at that time was 0. And she wasn't having hypos. So does that mean that how much variation? I don't know. This is one of the unexplored territories. What curve are we accepting is permissible in these patients? So what's not acceptable is a curve that looks like this. This is our Hill Howl, who was 4 kilograms. He's on 3 units per kilogram, twice a day of Prozinc, and it's not really touching him, is it? Okay, so what we did, we increased him using our CGM. We increased him, and we increased him, and we ended up on 5 units per kilogram. And we thought, yes, we've got control. Hooray! Thank God we left the device on, because guess what happened over the next 2 days? He went into diabetic remission, which lasted all of 4 days, and then you're going to need to go back onto it, which just emphasizes the point about acromegalics. Okay, what I just want to share you is this cat, Ollie, who is on velagliflozin, Senvelgo, which I love. Okay, I really like Senvelgo. Oh my God. Panic mode. Jesus, what are we doing to this animal? What do you think the blood glucose was? I might just put Teen on the spot. What do you think the blood glucose was? Normal. Actually, that's the point about Freestyle Libras. The blood glucose was consistently 8 in this cat. We were measuring it. The Freestyle was telling us 2. So, you know, unfortunately, I'd love to put one of the InSight ones on a cat with Senvelgo to see how close that is, because that's a very stable patient. You know, you cannot get more stable than when you're on Senvelgo. But the Freestyle read low all the way through. And yes, a problem. 9 kilogram Howard. Security t-shirt on, I love it. 11 units twice daily, not an unreasonable dose. He's not acromegaly, not hypothyroid. But yes, some things there. What does this all mean? Now, this is where I think it's important that we understand not to overreact to those with those Freestyle Libras, but maybe with the InSight, this will give us a bit better things. But he's actually pretty good. So I showed you a dog at the start and a cat at the end. This is what good looks like. Okay, in summary then, these continuous glucose monitoring systems are here to stay. Get involved, or your clients will just take it out of your hands and they will start putting them on their dogs themselves. They can buy them on Amazon. The InSight CGM is only going to be sold, as I understand it, through vets. So get control of it by using that one rather than doing that. Owners love them as a general rule. Look at the patient first and home records second. Then you can look at the data. Look at the AGP first and then individual days. And by all means, ask for help. This is new territory. Yeah? And these are complicated things and it's not necessarily easy. But please, 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 if you're going to send reports like this off to people, then include the salient details, like how much insulin the dog's on, how much food are you giving it, what's the protocol, how are they monitoring, how is the dog? Like a number of emails I get where that is not included, quite a problem. So please make sure you're giving us some of that background. Okay. Having started this talk saying we don't have to worry about dogs that are on insulin for 15 years because we don't have them, juvenile diabetics. This is Bailey, who was on things for teens. And just to point out still that I still think the biggest challenge facing canine diabetes is trying to prevent cataracts. And that's what we're really trying to do, is to prevent those cataracts because it's so expensive to remove them. It would be so much better if we did things. Thank you very much for listening. I'd be happy to take any questions. Can I please ask for you to wait until the microphone comes? Please, because I'm a bit deaf, and if you don't have the microphone, and no one else can hear you anyway.
I had a question about the graphs. On the app for the vet-specific one, do you get the averages?
Yes.
Yeah. Oh yeah, and how frequently do you change the dosage according?
So when I'm initially stabilizing it every 2 days, really that quick, until I start to see something. Yes, and then as I get closer to where I think I might be going, I start to decrease the frequency of changes.
Which is
yep, yeah. Be quite aggressive because I've got a monitor there. As long as you trust the monitor's telling you something. If it, you know, most of the, well, I mean, they're flat line 27 or 40. Yes, and you just increase it until oh yeah, now we're getting somewhere. Now we're getting there. Well, okay, let's see what's happening now. So I'm quite aggressive.
If it was reading high, but it was all fine in terms of like the clinical picture, would you not change it?
So if it's reading high, the glucose will be a 27. I don't believe that it's fine. I will be asking the owner more searching questions about polyuria, polydipsia. Okay. Glucose is an amazing osmotic diuretic. You know, and if you've got that level of glucose knocking around, I mean, something presumably, I mean, either the owner's lying or the machine's lying, because there's no way that dog or cat has a glucose of 27 in the skin and is not PUPD.
Thank you.
Okay. One's down the front here.
Do you find that in a very obese patient, the reading is different from Freestyle Libra, or is it still quite accurate?
Sorry,
in a very obese patient?
Obese patients. Okay. So, no, I mean, actually, obese patients are probably better than the thin ones precisely because you've got that the blood supply to the subcutis is not dependent on the obesity levels below. Fat does not have a good blood supply, but you're not putting it into the fat, you're putting it into the subcutis. histopathology. Go back to histopathology textbooks. Obesity dogs. I mean, an obese Labrador, the fat level doesn't start until you're that far through. Think next time you do a bitch spay, open them up and actually look at what you're seeing. You'll see that actually there's quite a difference. So yes, I don't think obesity is a problem, is the summary. Thinness is the problem. Unless the fat dog lies on the sensor.
Two things. We had an elderly client that had a phone, and you need to make sure they've got an NFC chip.
Yes.
She then bought a second phone that didn't have an NFC chip, so I had to get a third phone.
Okay, so I'll come back on that. What you're talking about there is a Freestyle 2. Freestyle 3 and the InSight CGM are Bluetooth. So you actually got to have Bluetooth capacity, okay? And the advantage of that is that you walk into the room and you're immediately connected on Bluetooth and you get the things download, whereas the Freestyle 2, you have to go over and actually scan it like the dogs are on the checkout at the supermarket with your near-field sensor. So that's one of the advantages of the Freestyle 3 and the InSight CGM is they're now Bluetooth and they're much better.
And how do you deal with the owners that, because they get the data as well, suddenly go, oh, it's looking high, I'm going to increase the dose, and not talk to them?
Okay, so we have one of the conditions of being in our diabetic clinic is that the owners don't do that. Okay, that's I just say, who's in charge here? Yeah, because if you start mucking around with the dose, I don't know what you're doing. I've had one owner out of, well, probably about 40, 50 now, one owner that started doing that. And there's a cat owner, and then she was giving 1 unit, then 2 units, then 1 unit, and she was giving insulin something like 8 times a day. Tiny little doses, and I could see it all happening, and she wouldn't stop. She wouldn't stop. She was a human nurse, and she just said, basically, I know it better than you do. And we fired her as a client. That's probably a bit harsh. I said, there's little point in you coming to see me for if we're you're listening to my advice very politely and going off and doing this. Yes, interesting dynamic. Okay, sorry, there's a one over here.
Sorry, it might be really basic, but in terms of helping the monitor stay on, what do you clean the skin with? Do you find that makes a difference?
Yeah, so so I haven't done any studies looking at different cleaning fluids. So what I do is we hibby scrub them, dry it down, then we take a Clinell wipe, so an alcohol wipe, and we wipe it two times, and then leave it to dry, because that's quite important, because we've tried to put them on and that doesn't work. But the other thing I then do is take a clean swab and I run it over the skin. I mean, the nurses think I'm like testing their sterility, but actually there are some dogs, miniature schnauzers particularly, even after all of that, you wipe it with a dry swab and it comes up black, brown stuff. So, okay, we go again till I get a clean swab, because cleanliness is absolutely vital. I don't need sterility, but I do need it to be really thoroughly clean. And I say miniature schnauzers. I don't know how perhaps they don't get as bathed as often, I don't know, but they certainly have that. And I would suggest probably some dogs with dermatological skin disease, that might actually be a problem, as opposed to dermatological non-skin disease. Hi, just one down here.
What is the highest dose of insulin you ever use?
There is no such thing as the highest dose of insulin. It doesn't exist. Whatever it takes is that the starting dose, 0.5 to 1 unit per kilogram. I'm probably tending on the higher end of that. Whatever it takes to get the clinical signs under control. Mike Hurtage, a colleague of mine, had a case. It was a 5 kilogram cat, and it was getting 80, or was it 60? 60 units of insulin twice a day to control its acromegalic diabetes. And that's what it took. That's just what it took. Okay? Obviously, you start off 1 unit increments. Yes, please don't do 6.5 units, 6.75 units, 6.95, 4, 3, 2, 1 units. It's 6 units, 7 units, 8 units, 9 units. Let's keep it simple. Owners can't measure that. So 6 units, 7 units, up to 10, then 12, 14, 16, 18, 20, then 25, 30, 35, 40, 50, 50, like that. So those are the kind of increments that you're making. But of course, you're much better if you've got a continuous glucose monitoring system to judge how close you're getting. Okay. Any more questions? One over there.
How many cases have you used the InSight on in cats and dogs?
Just the two, the data I'm presenting. Most of the stuff I'm doing here has been on Freestyle Libre. We're going to get more of the insights, and we're going to do more data on that. Which is why I don't want you to take a lot from here, but clearly those two. There are also colleagues of mine in Italy and in Denmark who are doing it. So it's not that there's only 2 dogs ever that have been doing it. That's an international effort to get this amongst the veterinary endocrinology profession. And we're all saying the same thing at the moment. These things just read a bit higher, and that's not necessarily a bad thing. But if you're used to using Freestyle Libres, and Federico Fracassi must have used 200-300 of them, I would think, by now, these Libres, and I've certainly used 40-50. So, there's quite a lot of experience with the Libras out there. They're great, and continuous glucose monitoring systems are great. But when you're changing system, you have got to do a bit of validation, and hats off to Woodley, who are actually prepared to validate these things. I'm not necessarily the most easy of laboratories to work in because of the fact that I'm doing it real time with real patients. It's very easy if you go and take a perfect model patient and things. My owners are my owners, and they have all the problems of loading apps and all the rest as any of yours do. So these things do need to be validated in real hospitals in real time. I never trust data from a dog that is presented that was presumably a model patient. You want a variety of patients. You want the data from 40, 50 dogs to actually be able to say, for sure, this is what's going on. You need that kind of number. If you validate a laboratory test, it's a minimum of 80 animals. Okay? Minimum. Obviously, I don't think it's economic to do it that or necessary, but they do need to be done on a lot of animals before you can be sure. So things like obesity and thinness and dermatological changes and all the rest, all of this can be factored into the equation. One last question, and then I think we'll call it, because I'm sure everyone wants to get to lunch.
That's maybe a bit silly question. And the case of ingestion of this device, because obviously this is made for humans.
Yes. It's not a silly question. It is actually a question that somebody raised.
Is there any risk of ulceration or after battery ingestion or anything like that?
I can't believe it. I can't. So I do a fair amount of endoscopy to remove foreign bodies. I do quite a bit. If you come to me with a radiograph of a continuous glucose monitoring system in the stomach of the dog, I will tell you to leave it there for a minimum of a couple of weeks. Okay? Get the owners checking the poo. It will pass. These coins pass. Okay? If after a couple of weeks it's not moved, then fair enough. In Spain, they use high fiber to do it. They actually suggest feeding asparagus. Well, I don't know about you, but I haven't seen the price of asparagus. There's no chance. But a high fiber diet to get the stuff moving, to get the bulk, and that bulk will carry the sensor out. There is stuff inside the plastic casing which, if it were to get out into the animal, could cause problems, but the plastic casing is protective. Yes, it's going to stop anything going there. These things, human beings are allowed to take a shower with them on. You can't get stomach acid into them that quick, and the plastic casing is obviously impermeable to the stomach acid. So if an animal were to take it in, I've never had it, but if an animal were to take it in, I would leave well alone for at least a couple of weeks before I ever went and start thinking about, maybe I've got to do an X lap and remove it and all the rest. But I've never heard of anyone having a case yet. But I'm sure somebody out there's a Labrador out there that just wants to be there. Okay, thank you very much for coming. Thank you.